Okay, so just go, Nate. Good evening, everyone, and welcome to June's BOMS Journal Club webinar, kindly supported by Ethicon tonight. And I'm delighted to welcome the team from Imperial Weight Centre London, a team very close to my own personal heart, having done my own fellowship there with Ahmed. And we've got a great programme for you this evening. But just before we kick off, a few dates. For your diaries for the next series of BOMS educational events. So the 23rd of June, we will run the next educational webinar, and we've invited Jamie Kelly from Southampton, who's going to be talking us through the endoscopic sleeve and his experience and some of the results he's got. On the 14th of July will be the next BOMS Journal Club at 8 p.m, run by the team in Sunderland. And on the 28th of July will be the next educational webinar. And we've got the fantastic Stephanie Sogg from the USA giving us a really, really insightful lecture. But back to the Imperial Weight Centre team, and it's my pleasure to introduce Ahmed and Alex Miras. And Alex will chair the evening tonight, and the team will present the two papers, an IHP paper followed by a surgical medical paper. So Alex, if you'd like to take over.
Sharif, Roxana, Emma, thank you very much for the opportunity to present. We have two papers. One is on enhanced recovery protocols perioperatively, that will be presented by our senior obesity specialist nurse Karen O'Donnell, and that will be followed by an important Lancet paper on mortality after surgery, presented by Anna Kamoka, who is an upper GI and bariatric surgery trainee and our ex-PhD fellow. So Karen, let's make a start. It's 8:03, so we have got 13 minutes up to 16:20. Thank you.
Okay, I'll just share my screen. Okay, so the paper that I have chosen to present is Outcomes of Enhanced Recovery After Bariatric Surgery Protocols versus Conventional Management in Patients Undergoing Bariatric Surgery. And this is a paper from the Journal of Laparoendoscopic and Advanced Surgical Techniques, authors Tamara Diaz-Velko et al. BOMS would like to thank and acknowledge Ethicon for their support for this event. So the clinical question that's been asked is, does the implementation of enhanced recovery after surgery protocol for bariatric surgery provide a streamlined process consistent with the current evidence, and does it correlate with improved outcomes? Looking at the background behind enhanced recovery after surgery protocols, these are standard care in multiple surgical specialties such as lower GI. The results have shown patients reach milestones faster with earlier discharge. This results in a reduced length of stay without any increase in adverse events or readmission. The implementation of enhanced recovery after surgery protocols focuses on decreasing surgical stress and achieving an early return to normal hemostasis for the patient. In the field of bariatric surgery, studies have already shown that enhanced recovery after surgery has been associated with improved outcomes when compared with conventional management. However, these protocols are still in their early stages in comparison with other specialties, and there are multiple variations of enhanced recovery after surgery protocols that are available. The interventions of enhanced recovery after surgery protocols occur at 3 stages during the patient's hospital admission, and these are in the preoperative, intraoperative, and postoperative periods. The aim of this study was to assess the association between enhanced recovery after surgery protocol implementation and postoperative outcomes for patients undergoing primary sleeve gastrectomy or Roux-en-Y gastric bypass. The outcomes that were measured were length of stay, management of postoperative pain and postoperative nausea and vomiting, the incidence of 90-day emergency department visits, readmissions and complications, and compliance to the enhanced recovery after surgery protocol. This was a retrospective review of patients who underwent surgery at the Mayo Clinic, Florida, USA. These were patients who were enrolled in the enhanced recovery after surgery program versus the conventional pathway. Patients underwent primary elective sleeve gastrectomy or Roux-en-Y gastric bypass between October 2016 and October 2018. There were 2 study periods. The first study period was between October 2016 to 2017, and this was the conventional management pathway. These were patients who were, whose management was not standardized, and it varied according to the surgeon's preference. After review of the available literature and the different elements of enhanced recovery after surgery, a protocol was then designed and implemented, focusing on 3 elements. The first element was the pre-operative intervention, and this was a meeting with the clinical nurse specialist where the protocol was explained to patients. Smoking and alcohol cessation was started at least a month prior to surgery. Patients were given incentive spirometry to begin practicing deep breathing, a pedometer to keep track of steps taken daily, and a carbohydrate-rich clear solution, which was a pre-op carb loading the night before surgery and again 2 hours before surgery. And that was if the patients did not have diabetes. Patients were also given an antiemetic prior to surgery. The anaesthetic protocol was standardized and was developed by anesthesia. It had guidelines on induction, post-intubation, maintenance, and analgesia for the management of post-op nausea and vomiting. Tubes and drains were avoided where possible at the time of surgery. In the post-operative phase, early mobilization was encouraged. Patients were expected to be out of bed within 2 hours of returning to the ward, and there was a 30, 60, and 90-minute challenge of fluids commenced on day 0. And this was patients started sipping liquids every 30 minutes, gradually increasing to a volume of up to 1.5 litres. The goal at the end of post-op day 0 was that patients were to commence on a blenderized diet. There was a standard schedule for pain medication and for post-op nausea and vomiting with a triple therapy approach. There was a total of 366 patients who underwent primary bariatric surgery procedures. The age, sex, BMI, and American Society of Anesthesiologists classification were similar in both groups. There was 193 patients in the conventional management group, and in that group, 99 patients underwent a Roux-en-Y gastric bypass, 48 were a laparoscopic approach, and 51 were a robotic assisted approach. In the enhanced recovery after surgery group, there was 173 patients, and of that group, 82 underwent a Roux-en-Y gastric bypass. However, 4 of these were a laparoscopic approach and 78 were a robotic assisted approach. The results showed that the 90-day perioperative outcomes, enhanced recovery after surgery was not associated with a significant lower median length of stay, 2 days versus 1. However, a number of the number of patients discharged on post-operative day 1 increased from 49.2% to 57.8%. Post-op visits to emergency department was significantly decreased with a p-value of less than 0.01, and the need for IV fluids due to dehydration was also significantly decreased with a p-value of 0.01. Compliance with the enhanced recovery after surgery elements, however, there was a couple of areas that stood out. The first was lack of mobilization on post-op day 0, commencement of diet on post-op day 0, and adherence to the schedule of post-op medication, in particular the analgesia and antiemetics. It did show an overall compliance of less than 80%, so the total overall compliance was 72.3%. When it looked at pain and nausea, the post-op average pain score was lower in the enhanced recovery after surgery group up to post-op day 2, but it wasn't significant. The use of opiate medications was significantly lower in the enhanced recovery group than the conventional management group, both intraoperatively and perioperatively. Overall, the post-op medication, the percentage of opioids in the enhanced recovery group decreased in comparison to the conventionally managed group, but there was an increased use in Tylenol and non-steroidal medication. Overall, post-op nausea medications were lower in the enhanced recovery group with an increased use of hyoscine patches. And the episodes of post-op nausea and vomiting on every day post-surgery were significant in comparison to the conventional management group. There was also a subgroup comparison made between the laparoscopic and robotic outcomes, and they showed no significant difference in length of stay or 90-day outcomes between the different approaches. The strengths of the study showed that the enhanced recovery after surgery protocol was standardized. There was a comprehensive assessment of important clinical parameters, and it was a well-written manuscript. The sample sizes, however, were generally speaking lower, given that the complication rate following bariatric surgery procedures is quite low. So if you wanted to show a statistical significance, a large cohort of patients would be required. There was a shift from laparoscopic approach to robotic approach in the second phase of the study. So this may be a potential confounder on the results themselves. The design of the study also didn't allow for the comparison of both groups at the same time. And this was a single site study, so may not be a representative sample. So for discussion, future work and clinical implications, I had a look to see if there was any randomized control enhanced recovery after bariatric surgery versus conventional management studies being undertaken in the UK. Back in 2014, Sharif Awad published a prospective study that was undertaken at our site at Imperial Healthcare NHS Trust that demonstrated that applying enhanced recovery after bariatric surgery protocols was feasible, safe, and associated with low morbidity. There was acceptable length of stays and a low 30-day readmission rate to hospital. The presence of multiple comorbidities should not preclude any use of such protocol within patients who are undertaking bariatric surgery. Prior to this publication, there was only one other published study in the United Kingdom, and that was an observational case series of laparoscopic Roux-en-Y gastric bypass patients that described a fast-track anaesthetic pathway. However, this study didn't utilize the traditionally described enhanced recovery after surgery interventions. There's also a randomized clinical trial published in 2013. This examined an enhanced recovery pathway versus a standard care of patients undergoing laparoscopic sleeve gastrectomy. The patients in the enhanced recovery after surgery group demonstrated significantly shorter length of stays, a reduced hospital costs, and no increase in occurrence of complications, but post-op nausea and vomiting and pain were not measured. So the question is, what is everybody currently doing in the UK? How can we standardize care pathways and protocols? And do we want to standardize these protocols or pathways? So in conclusion, the enhanced recovery after surgery protocol is associated with less pain and nausea episodes, a reduction in the use of nausea and pain medication, including opiates, a reduction in post-operative dehydration requiring IV therapy, and this has no additional adverse events or readmissions when compared to the conventional management group.
Okay, thank you very much, Karen. If you can just stop sharing your screen. And that was dead on perfect timing. Can I take the opportunity to introduce my co-chair for tonight's webinar, Emma Shuttlewood, who's a clinical psychologist from Coventry. And from tonight, we're going to have an IHP co-chair for each journal club. So welcome, Emma. And if you'd like to open the questions.
Yeah, no, thank you. Thank you so much for inviting me to be here as co-chair. Karen, really interesting paper. So obviously, as a psychologist, this is not my area of expertise, and we don't tend to spend a lot of time up on the ward and at that sort of surgery time. But I suppose I'm thinking about, again, it's a biased question because I'm a psychologist, but there's nothing there about sort of motivation or psychological well-being. And I wondered whether anyone's ever sort of looked at that as a factor and whether that influences that sort of immediate recovery after surgery in terms of moving around and eating and things like that.
So From our perspective within Imperial, patients are advised of the importance of early mobilisation after surgery. We also encourage our patients to be up, but we give them 4 hours before we get them up out of bed. And I think the patients who come through to bariatric surgery tend to often be very well prepared for what's going to happen at the time of surgery, going into surgery. I think it's not necessary. I think it's the longer term after surgery, that psychological support, they find that they may not have had what they need prior to surgery.
Yeah, that's interesting. It's making me wonder whether we're not that we're not prepared. I think a comment I hear from patients quite obviously, I see them like 9 months or so after the surgery, and often what they might see is they were really taken aback by how much pain they did experience. And so I'm not sure whether maybe we're not quite preparing them or they're not really considering that. And I suppose the reaction that can have on them thinking there's something wrong, I didn't anticipate it being this painful. But yeah, okay.
Is that long-term postprandial pain?
No, they talk about it just in the first sort of week or so, that they were just surprised. Like I try, and we try and sort of put that into our preparation now, is so that I think they don't necessarily anticipate it or expect it, and can be taken aback sometimes, I suppose.
Okay.
Karen, thank you very much for your presentation. We've had a few questions about carbohydrate loading pre-surgery, because obviously in bariatric protocols across the country we tend to do liver shrinkage diet for 2 weeks, but one of the key or fundamental key parts of ERAS for any types of surgery, colorectal cancer, thoracic surgery, and now bariatrics that's said here, is carbohydrate loading for the 12 hours before surgery. From a even technical or anatomical perspective, and from the patient's perspective, how much would that impact the surgery, do we think? Have the authors mentioned whether it does impact their, the liver size and therefore the success of surgery?
So in this paper, they didn't talk about the impact of the carbohydrate loading diet on patients' outcomes. However, I know in the paper that Sharif actually wrote on, there hadn't been a huge amount of agreement on whether or not patients undergoing bariatric surgery are able to have a carbohydrate loading diet because of the impact on gastric emptying, or the gastric emptying after surgery, from what I can remember. I can defer to Sharif for that because he may be able to answer that.
Yeah, no, I mean, thanks, Ahmed, for leading me into this. I didn't realize I'm in the spotlight here, but no, I mean, at the time in 2012, 2013, when I was in Imperial and we did this study, which was the second study on ERAS within bariatric patients to be published, there wasn't much data about carbohydrate loading in the bariatric setting. The main purpose of it was to try to reduce insulin resistance perioperatively, immediately before the operation. And that was done with Ole Lundquist's work a decade earlier that used glucose and insulin clamps to demonstrate the reductions in insulin resistance. Now, in the bariatric setting, who are already carb depleted, and that, the liver diets could potentially enhance insulin sensitivity prior to surgery, as well as with the use of laparoscopic surgery, I can't see that 2 carbohydrate loads immediately before surgery would lead to any meaningful clinical benefits. Hence, it's not being studied within a randomized setting. Okay, one more question and then we'll move on. So we've had a question here. Karen, what do you think about the data, or 2 questions rather, than move on, the data showing reduced complications within the ERAS group? Why? What do you think the mechanisms of that is?
So the complications, or the complications relating to nausea and vomiting and pain?
Okay, so that's the main components. And what's your view about the use of incentive spirometry, the importance of it, and early mobilization within ERAS protocols, especially within the bariatric setting?
So I suppose, the use of incentive spirometry is to reduce the risk of chest problems post-surgery, so chest infections, potential pneumonia, and early mobilization to help with reducing risk of DVT, PE after surgery. And that's the main reason we use it, main rationale for using it.
Okay. Okay, yeah, and it's surprising how many units actually don't use incentive spirometry in their perioperative bariatric protocols. Okay, so I'll hand over to Alex if you'd like to introduce the next speaker, but we're doing very good for timing, so thank you.
Yep. So thank you, Karen. Very well done. Anna Kamoka is an upper GI and bariatric surgery trainee, but she spent a lot of time with us at Imperial doing her PhD. And she will be presenting an important paper from the Lancet, one of the biggest, probably the biggest, I suppose, meta-analysis on mortality outcomes after surgery, and it incorporates some very nice randomized and non-randomized, it incorporates some nice studies within it, including the SOS. So really important in terms of changing even policy. Anna, thank you very much.
Thank you very much, Alex. Let me just share my screen. Right, I hope you can see that's right. So thank you very much for this opportunity. It's a great pleasure and privilege to be here and to represent the Imperial College. So as obviously Alex already introduced the study I'm going to present. It's only been published in the Lancet last month, and you can see quite a few well-known names here in the authorship. And this study is a result of collaborative work between the centres from Singapore, Seattle, Boston, Melbourne, and London. So we would like to obviously thank Ethicon for the ongoing support of this meetings. Now, in terms of backgrounds, our knowledge about the medium to long-term outcomes of obesity and metabolic surgery comes predominantly from the observational cohort studies. Now, the trouble is that with the bariatric surgery, the numbers of mortalities, unlike in cancer studies, are very low indeed, and that makes quite difficult to quantify the treatment effect of the surgery that we perform. Therefore, the authors of this study decided to perform quite an impressive meta-analysis when they looked for studies that compared all cause mortality after metabolic and obesity surgery versus non-surgical management of obesity. They use quite a robust methodology here. They use the usual assessment for the risks, bias assessment, etc. And they essentially, in order to be able to assess the data from those longitudinal cohort studies, they downloaded, pre-processed and digitized the images of the survivor or the failure curves to obtain their step function and the timings of those steps. And from that data, then they were able to obtain the survival information on an individual patient level. And these are the results that they'll be coming up with. So these are the inclusion and exclusion criteria. They've included all the studies published until February this year. They've analyzed the studies with the low risk of bias only. And they excluded this study that enrolled patients with other significant comorbidities such as type 1 diabetes or end-stage renal failure. So they screened through over 1,400 studies and ended up with performing meta-analysis on 17 of those, 16 being cohort studies and one of those being a prospective controlled trial, which was obviously the SOS trial study with its long-term data reports. So this is really impressive in terms of numbers they came up for this meta-analysis. They gathered over 170,000 patients with a median follow-up of just under 6 years. And in that cohort of cumulative cohort of patients, they had just under 8,000 deaths recorded, which translates into about 4.5% mortality rate there. And as you can see in the points lower down on this slides, the patients who underwent a metabolic and obesity surgery had a lower mortality rate compared to the patients who were non-surgical matched controls, and I'll come into more details with those numbers in a second. So in terms of the overall survival benefits, I mean, we all know that metabolic and bariatric surgery is expected to, from the studies that are published today, to reduce the hazard rate of death. But the numbers that they're shown in here are really impressive, as they're reaching almost 50% reduction in the mortality rates. And that's translated into the numbers needed to treat. In the 10-year span, 24 procedures should be done to prevent one death in this cohort of patients. And when we move on to the 20-year span, this number drops down to only 11 patients. And that further translates into the simple fact that bariatric and metabolic surgery extends patients' life expectancy by 6 years. The authors also did some subgroup analysis, and I moved to some of those subgroup analysis now. And one of those looked into different types of surgeries, and surprisingly, they did not see any differences between the 3 main types of surgeries performed. Now, this is just coming back to the overall analysis that I've just showed you. You can see briefly in the top graph, the red lines represent the non-surgical controls, and the blue ones are the patients undergoing surgery. The 2 interesting things you can see on this graph, obviously the benefit of metabolic surgery in terms of reduction of cumulative mortality is quite obvious when looking at those graphs. But interestingly, you can see that those 2 lines actually start diverging very early on. You can see that as early as 2-3 years post-operatively, you can already see those lines diverging. And that's why it may not be statistically significant at that stage as yet, but you can already see the trend of improvement in survival of these patients. Now, the second interesting thing that I've noticed, and authors did not quite comment on that, is that you can see there is this step at the 18 years time point, where both of the curves start going up quite steeply. And I'm not quite sure what the reason for that is, but I can only assume that that's to do with the age of the population. Obviously, the patients we operate on are usually in their late 40s or early 50s on average. So by the time they're going down 20 years down the line, they're reaching the age of 70. And this is why those 2 curves would be going up, as patients would be dying of other causes. And below you can see the breakdown of all the studies included in this meta-analysis, and they follow the all but the Hassinger study, which looked actually in the outcomes in the elderly population. All the others show very clearly follow these positive lines presented above. So this is a very important slide, as this subgroup analysis looked at the patients with type 2 diabetes, and you can see that the benefits in patients with obesity and type 2 diabetes is very impressive indeed. You can expect up to 60% reduction in the hazard rate for all-cause mortality. And the numbers needed to treat here are pretty impressive indeed, as well, as 1 death per 10 years could be averted for every 8 patients we operate on. And when we move on to the 20 years span, that number needed to treat decreases down to 5 years. And the other important thing when having informed consent and discussing the options of treatment of our patient is that for every patient with type 2 diabetes and obesity, we can expect to extend their median life expectancy by 9 years. The numbers with patients without type 2 diabetes are not that impressive. Nevertheless, they're still much more significant than in matched controls managed non-surgically. And this graphs just represent the cumulative mortality for the subgroup analysis that I've just discussed. And you can see that essentially patients with type 2 diabetes benefit from the bigger and earlier effect than the patients without type 2 diabetes. The authors also performed quite an interesting simulation here. They have looked into potential benefit globally wise of increasing penetration of obesity and metabolic surgery. So their theory was that, their assumption was that there are over 180 million people worldwide having severe obesity. I'm not quite sure how they came up with this exact number, because they didn't specify sort of what was their cutoff in terms of other BMIs or comorbidities of classifying severe obesity. Nevertheless, we know from various studies that the uptake of metabolic bariatric surgery at the moment is less than 1%, and that's certainly true in the UK as well. And about a third of patients who have obesity and are undergoing bariatric surgery also suffer from type 2 diabetes. So the authors have pulled all these numbers together and the results of their study, and they came up with this really impressive results that says that if we increased delivery of bariatric and metabolic surgery by only 1%, we could potentially save the potential future over 5 million life years in the patients with diabetes, and over 6.5 million future life years in patients without diabetes, because obviously of the volumes that we could be doing. So I thought this was quite an interesting experiment that they've run in here. So, I mean, this is certainly, I mean, this is the largest meta-analysis in the field I have seen. I'm not aware of anything, any more impressive numbers than those. The authors looked into those 17 good quality studies and showed very clearly then metabolic and bariatric surgery is associated with approximately 50% lower rate of all-cause mortality when compared to the matched population with obesity that is treated non-surgically. They have also shown that patients with type 2 diabetes benefit more than the patients with just obesity or other comorbidities. Apart from numbers and the very robust methodology, the strengths of this study comes predominantly from the type of data that we're getting a black and white information that can guide the healthcare professionals, the patients themselves, and the policymakers of what degree of benefit we are actually able to provide in here. In terms of the limitations of this study, so obviously, I mean, by design, if when analyzing data from observational studies, obviously there inherently will have some bias, such as attrition and non-adherence and data collection bias. I've noticed that in the studies that were analysed, obviously the matched non-surgical cohorts were varying between the studies. There was quite a lot of heterogeneity in there, because some of the studies used the non-surgical patients who had pretty much no interventions whatsoever. They were just run in the community with some with a bit of social prescribing and mild, very sort of mild lifestyle interventions, and that varied to patients that were running through proper weight management programs, such as our equivalents of our tier 3 services. So there was a bit of discrepancies in that. Now, the other thing is that obviously those are the studies with the very long-term outcomes. So we're looking at the patients that were introducing those studies for over 3 decades. As we know, there has been quite an impressive development of in the field of pharmacotherapy management of type 2 diabetes and obesity in the recent years, and especially, as I'm sure you know, the semaglutide, for instance, has been just approved by FDA last Friday to treat obesity. So obviously, including that pharmacotherapy in those studies could affect the results, could diminish the effect size, but nevertheless, I'm sure that it will still be one. The patients did not, the authors did not really report on patients' patient level covariates, which could influence the data. So that's something that could be looked into as well in here. And they themselves admitted that their surgical subgroup analysis may be prone to bias due to the methodology they used for that particular analysis. So just to wrap up in terms of the future work that could be done based on such studies, I mean, we could look more into the details of where does the benefit from the reduction of mortality come from, whereas that would be similar to what's been so far already reported in the SOS studies, such as cancer mortality and cardiovascular mortality reductions. So that would be an interesting thing to see. The other thing is in the future, I think we'll be moving obviously from just comparing surgery versus the lifestyle or medical management, because we know that there is a synergistic effect of combining the surgery with pharmacotherapy. So obviously this is the sort of lines that the future studies should be going for. And last but not least, as I already mentioned, this study is a very strong tool that we can use in terms of dealing with in dialogues with our policymakers, but also with the GPs to avoid this kind of postcode lottery, to actually show the hard data to GPs and other healthcare professionals that there is a reason why you refer patients to our services. So to sum up, the surgery is associated with the substantially lower all-cause mortality rates, and it makes our patients live longer, and patients with type 2 diabetes will be the ones that will benefit most from it. Thank you very much.
Thank you so much, Anna. That was a fantastic presentation, and it's incredible to see kind of really impressive numbers. I think those are certainly the highest that I've ever seen in papers in terms of mortality benefits of bariatric surgery. Are there any other procedures that can compare to this in terms of numbers needed to treat? Do the authors actually clarify in terms of, you know, clinical benefits from other surgeries or in other sectors, non-cancer wise, that would give comparable results like this?
You mean in the field of non-bariatric surgery? Or no, they did not allude into any of those studies, and I think it would be a bit tricky, obviously, to compare to cancer populations this kind of studies, because we're dealing with completely different populations in a different life expectancy. Our patients are much younger than patients that are undergoing sort of cancer surgery, so I think it would be quite difficult to compare to those. When it comes to benign surgery, I mean, obviously you could be looking into the benefits of things such as trauma orthopedic surgery, and what kind of benefits would that be. But I don't think that you would be looking in those type of surgeries in so much of the survival improvements, but you would be more looking into sort of improvement of quality of life. So it's a good question, but I'm not sure whether there's anything else we could compare to directly. Okay,
and in terms of, just to add, in terms of like they're looking at mortality and kind of all-cause mortality, but was there any mention of like healthy life years ahead that were improved at all? Because that's another aspect. If we've had such an improvement in, you know, life expectancy, surely the years of healthy life we know will be far more than 6 to 10 that's been reported.
So they did not look into it. It's a very good point, and a very valid one as well when we're looking into the outcomes of surgery. They did not look into that, and I'm not sure whether that would be something that would be feasible to get from the large cohort studies. Obviously, ideally, if you wanted to have a perfect studies, you would design them this massive randomized controlled trials to look into that, because then you would avoid all the bias, you could get all the information. But realistically, we know that the RCTs for such numbers of patients are just never going to happen. So we need to rely on the information that we have, and we restricted to that. So obviously that, I think that would be quite difficult to obtain.
Thank you.
Thank you, Anna. That was a great presentation. I thought I understood stats until I read that paper and was like, really nearest to neighbour matched. I was like, that's not something I've ever heard.
Trust me, I spent a lot of time on Google when I was going through the methodology as well to understand it fully.
So it was, no, you did a great job. It was really great. And Roxana slightly stole my question there, because I was really interested in this. You know, it's very focused on survival and not talking about quality of life of that survival. But yes, Ahmed asked a question which is really kind of, given this finding and the sort of really, you know, clear, obvious sort of benefit, should we be prioritizing patients with type 2 diabetes, particularly given our long waiting lists? What do you think?
And I think I was expecting someone actually might ask this question, because with our supers, we were discussing before, long waiting lists that are going up into sort of 3-4 years between the centers. I think this is the discussions in every MDT nowadays, when we're trying to catch up with the COVID backlog. Who are we actually trying to benefit now? Because we know that some of the patients that are on the waiting list, if they wait for 4 years, by the time they get to the surgery, they also have an MI, complications of type 2 diabetes, and maybe this other patient investigators, we have actually missed the boat, and we should concentrate on the patients who are younger with a shorter duration of type 2 diabetes, and also, as you've mentioned, patients that actually do have type 2 diabetes to have the sort of health-wise and economically the best outcomes that we can within the very, very limited pool of what we can actually deliver in the UK. So I think that's a very good question. So I do think that we should be concentrating on patients with type 2 diabetes.
And I suppose to follow that up then, I mean, how do we, if that's the case, how do we move forward with that? How do we decide that as a kind of, is that a BOMS thing, or I don't know?
It's a difficult question, and I know that having discussed these things with my colleagues, this is a lot of, that's what the individual MDTs in various centres are discussing, but perhaps that's something we could pick up on the BOMS this year and discuss it between us as well, just to see whether we can come with a consensus.
Yeah, great idea.
So I'm glad you Googled all the research methodology, Anna, because I've got a question for you. Can you just explain to us?
Oh, no.
Yes, you can't get away that easy. So what does reconstructed individual participant data mean?
So the way I was trying to understand is they basically, in my simple, I'm not a meta-analysis, obviously, I'm not going to pretend that I am, and I've pretended to do a bit of research with my PhD and my RCT, but so my understanding in here is that they were trying to sort of strip down the data, because obviously the survival curves are the data that are presented over the cohort that you see, and this is very nice visual presentations, and by downloading the Kaplan-Meier curves that they were doing, they were sort of digitizing those images, and the way that it's sort of, I understood it, is they were sort of breaking that down, the data that were delivered in all those cohort studies, and then basically doing like a reverse sort of analysis to get back down to, with this reverse Kaplan-Meier curves, to get down to the bottom, to the sort of individual patients' outcomes. So that was my understanding of it, but correct me if I'm wrong, obviously.
I'm not going to challenge you on that. So,
I'm glad.
Thank you. We've had a question from Spain from one of our regular attendees, Elena. So she's asking, did the paper describe any differences in survival outcomes between sleeve and bypass in patients with and without diabetes?
So they did not report the analysis, the sort of subgroup analysis within the surgical cohorts by breaking them down further into the sort of type 2 diabetes versus non-type 2 diabetes. And it was quite interesting when I looked at so they only looked at sort of cumulative. So they compared bypass, sleeve and band overall, and it was interesting because they said that they didn't see any difference at all, which I found a bit surprising, because obviously I wouldn't expect that you would save so much benefit after a band as you would after a sleeve or bypass. But nevertheless, they're saying that their methodology might be underpowered to detect the differences between the groups per se, so that's why they didn't break it down further. And this statement surprised me, because I don't know if this study can be underpowered for anything. I don't know what can be powered to sort of detect such differences. So I think this is the reason why they didn't break it down further in those surgical subgroup analysis.
So there's a huge attrition rate in this study. If you look at the Kaplan-Meier curves and you look at the numbers at risk at the bottom of the graphs, after 10 years, they have less than 10% of participants who they are reporting outcomes on.
As expected in the longitudinal
studies. That's quite a high attrition rate. Fair enough. Okay, so we're almost out of time. Just before we finish, I've got a question for Ahmed actually, if you can just unmute yourself. And this is just to save a lot of queries from the audience. So in terms of those lovely paintings you've got on the back wall of your manor, can you just enlighten us as to where they come from?
Of course, they're from Florence, the Palazzo Uffizi. So in this day when none of us can travel, I thought it'd be nice just for the audience to get a little bit of, of foreign culture.
It's lovely, very appreciated. Thank you very much. So thank you, Alex, Ahmed, Anna, Karen, and Emma co-chairing, and Roxana co-chairing. And thank you very much for joining us. Just one more reminder of the dates. 23rd of June, that's in 2 weeks, is the next educational webinar on endoscopic sleeve, Jamie Kelly, Southampton. 14th of July, the BOMS Journal Club with Sunderland. And 28th of July, the educational webinar with Stephanie Sogg. Thank you very, very much for joining us tonight, and for the great team from Imperial. Good night.